Introduction. Welcome to today's lecture on gastrointestinal motility disorders. In this extensive script, we will explore various topics related to the pathophysiology, diagnosis, and management of different gastrointestinal conditions affecting motility. Understanding these disorders is crucial for medical practitioners, as they play a significant role in the overall function of the digestive system. Now, let's delve into the 12 distinct topics that we will cover throughout this script, starting with achalasia, pathophysiology and treatment. Achalasia is a rare disorder where the lower esophageal sphincter fails to relax during swallowing, leading to food not being propelled into the stomach and the esophagus becoming dilated. Treatment options include medication, endoscopic procedures, and surgery. The choice of treatment depends on the patient's individual factors. Gastroparesis is a condition where the stomach empties slowly. It can be caused by diabetes, functional disorders, or neurologic issues. Diagnosis involves symptoms and tests. Treatment includes dietary changes, medications, and surgery if needed. Intestinal pseudo-obstruction is a condition where impaired intestinal motility mimics mechanical obstruction. It can be acute/chronic and primary/secondary, with various causes. Symptoms include abdominal distension, constipation, malnutrition, and the diagnosis involves comprehensive evaluation with different tests. Management includes symptom relief, improving nutrition, and addressing underlying causes. Rapid gastric emptying, or dumping syndrome, occurs when stomach contents are emptied too quickly into the small intestine. This causes gastrointestinal and systemic symptoms. It is common in patients who have had gastric surgery. The condition involves altered pyloric function, disrupted feedback mechanisms, and accelerated nutrient transit. Symptoms include abdominal pain, diarrhea, weakness, and sweating after meals. Treatment includes dietary changes, medications, and sometimes surgery. Scleroderma, an autoimmune connective tissue disorder, is often associated with esophageal dysmotility. Esophageal involvement in scleroderma can manifest as impaired lower esophageal sphincter relaxation, reduced esophageal peristalsis, and decreased esophageal compliance. Patients with scleroderma and esophageal dysmotility commonly present with dysphagia, reflux symptoms, and a predisposition to esophageal strictures and Barrett's esophagus. Diagnosis involves a combination of clinical evaluation, barium swallow studies, high-resolution esophageal manometry, and esophagogastroduodenoscopy. Management of esophageal dysmotility and scleroderma focuses on symptom relief and prevention of complications. This may include lifestyle modifications, proton pump inhibitors, prokinetic agents, and, in severe cases, endoscopic or surgical interventions. Colonic inertia causes chronic constipation due to decreased colonic movement. Diagnosis includes excluding other causes and testing for delayed colonic transit. Treatment involves dietary changes, laxatives, and surgery in severe cases. Hirschsprung's disease is a congenital disorder where ganglion cells are absent in the distal bowel, causing functional obstruction. Diagnosis involves clinical suspicion, rectal examination, contrast studies, and rectal biopsy. Surgery is the main treatment, with options such as the Soave, Swenson, Demel, or transanal pull-through procedures. Chronic idiopathic intestinal pseudo-obstruction is a rare disorder with unknown cause causing impaired gastrointestinal motility. Molecular mechanisms may involve neuromuscular signaling abnormalities, smooth muscle dysfunction, or autoimmune phenomena. Diagnosis requires excluding other causes and extensive evaluation. Management is symptom-focused with prokinetic agents, nutrition support, bowel rest, and sometimes surgery. Small bowel dysmotility is a common gastrointestinal complication in patients with systemic sclerosis. It involves abnormal contractile activity, leading to dysmotility, malabsorption, and bacterial overgrowth. Clinical manifestations can range from mild symptoms like bloating and diarrhea to severe malnutrition and weight loss. Diagnosing small bowel dysmotility and systemic sclerosis involves a combination of clinical evaluation, radiological studies such as small bowel follow-through, and manometric assessment of small bowel function. Managing small bowel dysmotility requires a multidisciplinary approach. Treatment modalities may include dietary modifications, prokinetic agents, antibiotics for bacterial overgrowth, and parenteral nutrition for severe cases. Post-infectious irritable bowel syndrome, PIIBS, is a condition that develops after an acute gastrointestinal infection. It is characterized by persistent or recurring symptoms of irritable bowel syndrome, including abdominal pain, diarrhea, and bloating. The exact mechanisms behind PIIBS are not fully understood but are believed to involve dysregulation of the gut-brain axis, impaired gut barrier function, and alterations in the gut microbiota. Managing PI-IBS involves a comprehensive approach that includes dietary modifications, probiotics, gut-directed behavioral therapy, and symptom-directed medications. It is essential to address the underlying psychological factors and provide appropriate support to improve the patient's quality of life. Neurogenic bowel dysfunction is impaired bowel movement caused by nervous system damage. Conditions like spinal cord injury or strokes can cause this. Assessment involves history, physical exams, and tests. Treatment includes medication, dietary changes, biofeedback, and surgery if necessary. As our understanding of gastrointestinal motility disorders continues to evolve, there are exciting prospects for future research and advancements. Several areas warrant further investigation, including the development of novel diagnostic techniques, identification of potential therapeutic targets, and the exploration of emerging technologies like bioelectronic medicine or tissue engineering. By expanding our knowledge of the underlying mechanisms and improving diagnostic and therapeutic strategies, we aim to enhance patient outcomes and quality of life for individuals affected by gastrointestinal motility disorders. In conclusion, understanding gastrointestinal motility disorders is crucial for healthcare professionals. We explored achalasia, gastroparesis, and other conditions affecting motility. By staying informed, providers can improve patient care. Thank you for joining this educational journey on gastrointestinal motility.